I will teach you what is the method of actually seeing a X-ray. That is basically is required. You may not be able to see everything in your postgraduate days. So we start. So X-ray. What is an X-ray? X-ray is basically a light which you cannot see. So it is an electromagnetic wave. It lies between the gamma frequency and the ultraviolet frequency. Between that is the X-ray. So who invented the X-ray? Röntgen. Now what is the full name of Röntgen? Where was he from? W is all right. Wilhelm Conrad Röntgen. So Wilhelm Conrad Röntgen was a German physicist. So he was a very brilliant person. He was the one, after invention of this, he was the first Nobel laureate. What do we see really? Can you tell me what is that? This is the first X-ray that Röntgen took of his wife's hand. And the comment that the wife gave was, "I could see my death." Is a famous quote from Röntgen's. She could see the bones, na? So that is why she said, ki, "I could see my death in this picture." So Röntgen's wife's X-ray hand, and there is a ring there. This is the first X-ray that was ever taken. So what do we see in an X-ray? We see the bones and spines. We see the lung, trachea and bronchi to a certain extent. We see the heart. So in the heart, what do we see? We see the right atrium, the left ventricle, the aortic knuckle, the pulmonary conus, and the left atrial appendage. It is not the left atrium as such. It is the left atrial appendage that we see. Okay. So, and we see the diaphragm. We do not actually see the diaphragm. We see the silhouette of the diaphragm. So silhouette is a word that will be used very frequently in X-rays. Silhouette is a shadow. The edge of a shadow is known as a silhouette. So silhouette of the diaphragm can be seen. The cardiophrenic, the claustrophrenic recesses, and the fundal gas. These are the things that you will see in an X-ray, basically. There will be so many other things, but if somebody asks you what do we see in an X-ray, these are the things that we normally see in an X-ray. Okay. So there are few more things to see. So what are the few more things? These are lines that are seen in the X-ray, which gives you a fair idea of what is behind the heart, behind the mediastinum. So these are the right paratracheal stripe, which should be around 2 to 3 millimeters. It's a very small line-like thing. I'll show you. There are X-rays. Azygo-esophageal line. The azygos vein will go up and drain into the superior vena cava, if I'm not wrong. So superior vena cava, it will drain in. So that azygos vein silhouette can be seen around by the side of the esophagus. You will see the para-aortic line, you will see the paraspinal line. So few of the causes of right paratracheal line widening is mediastinal nodes, fluid overload, in heart failure, in pleural thickening in the medial part. If there is mediastinal pleural thickening, then you will find right paratracheal line widening. In the right paratracheal line is a very important structure which you should be able to see, because it will give you a fair idea about the mediastinal structures. Okay, anything in the mediastinum will cause a widening of the paratracheal, right paratracheal line. Left paratracheal line is not really very important, not very well delineated. I will show you the X-ray of the lines. As I go esophageal line, see what these were the things that were diagnosed before CT was there. Now they could, by seeing the azygos esophageal line, you could see hiatus hernia, you could see esophageal disease, you could see left atrial enlargement, you could see subcarinal nodes, bronchogenic cyst. Everything could be diagnosed just by seeing these lines. Unimaginable now with an X-ray. Now you will do a CT mostly, but you should know that this could be actually made out in an X-ray itself. So there are some hidden areas where you don't tend to actually look into, or you miss. These are the apical zones, because the apical zone, the thoracic cavity will go up like this and it will form a dome. Na? So that dome area, there are ribs, and there might be cervical rib, the first rib. So there will be a hocus pocus in the upper part. So apical region is something which you should always look for. The hilar zones, we don't know the hilum, that is why we don't know how to see the hilum. So I will stress on hilar zones as well. The retrocardiac zones, the heart is going to obliterate everything. So how are you going to see the retrocardiac part? There comes the importance of the left or right lateral view X-rays. Okay, you can see the retrocardiac areas very nicely there. Okay, and the zones below the diaphragm. Below the diaphragm is very difficult on a PA view or AP view. A lateral view I will show you very beautifully, will delineate where is the diaphragm and the retro diaphragm spaces. Okay, so these are the hidden areas which you should know to see. So a systematic approach to an X-ray is the crux of the whole thing of seeing a X-ray. So the first thing, the second, I should have put that one on the first. The identity of the X-ray. You should always see whose X-ray you are seeing. Otherwise, you may end up seeing somebody else's X-ray. That is the most important thing. Identify the right and the left. Mostly, it is written there. If it is not written there, it is very, very difficult to find out which is the right and the left. In a complete reversal of all, it is very difficult. Only a dextrocardia you can very well make out. But if the whole thing is reversed, then it is very difficult to make out unless it is marked. Okay, so but that will be a mistake done by the radiology, not us. So identifying the right and the left. So what are the quality of the X-ray? What do we see in a quality of the X-ray? Mnemonic known as RIPE, R-I-P-E. You see the rotation, you see the inspiration, you see the projection and the exposure. It is easy to remember that way, RIPE. Okay. So what is rotation? See, I will show you, there are few slides later on, just try to remember. Rotation is you shine a light through the patient's body and there is a detector at the back. So when you rotate the patient anyway, the shadow is going to differ. So there is a standard position of the patient which will give you a standard X-ray impression. Only by then you can make out what is there in the shadow. Otherwise, if I rotate and take the X-ray, you might feel everything has gone hocus pocus. Definitely yes. Rotation can be seen by the spinous processes midway between the medial end of the clavicle. So you will identify the clavicles, the spinous processes of the vertebra should be at the midline. It should be equidistant from the ends of the clavicle. Okay. So the trachea, this is how you see the rotation of the heart, rotated feeling, not the heart, sorry. The trachea, heart, lung will be difficult to comment on a rotated feeling. You can make out shadows in the lung, but you will not be able to comment anything on the tracheal position, on the position of the heart, the cardiac size, everything goes haywire in a rotated film. So don't, if somebody gives you a rotated film examination, don't try to comment on these three things, or try to make out ki really it is intentionally rotated. So there are oblique films which can be taken to find out some very specific spot in the lung. So I will not go into the oblique films. These are more given in radiology people. We don't require it. So, and inspiration or inflation. So the X-ray is taken in a inspiratory phase. You do not take an X-ray on the expiratory phase. So the How do you know it is adequately in a inspiration? The right diaphragm should be intersected by the anterior end of the fifth rib. Around the fifth rib, the anterior end of the fifth rib should intersect the middle of the diaphragm on the right side. Okay. 8, 9, if you see the posterior part of the ribs, the 8th, 9th rib should be around the area of the, normally should be around the area of the shadow where the diaphragm is. But the anterior end of the, this is what we do, anterior end of the ribs, we count and see if it is in the 5th, 6th space, 6th rib intersecting the middle of the diaphragm, then we say that it is a adequate inspiration film. Okay. Any doubt? Just so beyond 7th rib, we say it is hyperinflation. We will see X-rays. We can come back to that later on. So this is one of the most important thing: the projection of AP versus PA view. Yeah? So how do we make out AP and PA view? We see these three things. One is the scapula. You know how a X-ray is done, no? Have you seen an X-ray being done, or you must have done it before? So you hold like this and you brace like this, so that the scapula goes out from the lung fields. No? So this is what you will see in PA view. The scapula will be outside the lung fields. If it is inside the lung fields, then in AP view it is within the lung fields. And second thing is the clavicle. In PA it will be oblique, and in AP it will be horizontal. And the ribs, the posterior ribs are better visualized in a PA view. The first thing that you see is the ribs. These are the posterior ribs. If you see the anterior ribs very nicely, then it is a AP view, I think. Okay. How do you know the exposure of the film? Overexposure and underexposure. So when you see the thoracic spinal shadows, the fourth thoracic, up to the fourth thoracic spine, it should be well visualized. Beyond the fourth thoracic spine, the spines should be very faint. If the whole spine and the spinal spinous processes are visible, then you know it is the exposure was more, so lungs will look more black, and everything, the smaller details will go. So exposure should be proper, so that the spine should be faintly visible behind the heart. Above the heart, the spines are very beautifully, the spine should be visible. Behind the heart, it should not be very visible. I will show you when the X-rays come. So, how do we see an X-ray? So, there are basically two approaches. One is known as a inside out approach. One is known as a ABCDE approach. Whichever you do, you don't try to miss out things. Otherwise, you will tend to miss out few things. So, what is an inside out approach? It is, you see the heart, you see the hyla mediastinum, you see the lung, you see the thoracic wall and the bones, and the abdomen. So, this is the inside out approach. Okay. And what is a ABCDE approach? I like this approach very well. So, airway, you see the trachea, carina, bronchus. Comment, I always write, comment on the trachea only if there is no rotation, otherwise don't write. B is breathing, so you see the lung fields. So, what do you see in the lung fields? You see consolidation, effusion, mass, batwing opacities, ARDS, pneumothoraces, nodules, calcifications, etc. In the bones, you see the quality, the fracture, and the hypodensities. Huh? C is cardiac, borders of the cardiac cilia, and cardiothoracic ratio, the shape of the heart, etc. There are so many things that are there in the cardiac, but these three are the main things that you will see. D is for the diaphragm. You see the contour of the diaphragm, you see the fundal gas shadow and the gas under the diaphragm. These are the three things that you see when you see the diaphragm. And E is for everything else. So everything else is catheters, pacemakers, clips, wires, artificial valves, soft tissue, etc., etc., etc. So this is another approach where you don't tend to miss out anything. So what should be basically the approach? The approach should be to detect the abnormality first, where it is, recognize the pattern. So there comes the pattern recognition in an X-ray, and formulate the diagnosis and differential diagnosis. So this is how you should approach it. Your examination questions will also be like this. Tell me about the X-ray. So you will be starting from the inside out approach or the ABCDE approach. Then you will go to the directly to the pathology itself, what you see, description of the pathology. You will recognize the pattern and try to formulate a diagnosis and a differential diagnosis. This is how you do it. So what are the things that you will see? Just in one slide, if it is possible, I have brought it out from some place. So you see the outlines of the bones, you see the aortopulmonary window, you see the check and compare the hilar positions, densities and morphologies, check the soft tissue, densities behind the heart, diaphragms, gas under the diaphragm, assess the heart borders, the azygos recess. This is where the azygos vein will drain into the superior vena cava. The azygos veins comes like this and comes and drains here. You will see in the lines, I will show you later. So carinal angle, check the epices for tumors, etc., etc. So these are the things. So inside out approach basically will give you an idea. So see, this is a projection of the AP and the PA view. The PA view is around 6 feet. The source is fixed at around 6 feet from the patient. So everything is fixed. The patient is going to stand in a particular position. Source of the ray will be at a certain distance, so which are all measured, and then you take the X-ray. So you see, if I change that to AP view, you don't know where the source is. It will be much nearer than a PA view. And see what happens when you turn the patient around and face the source. You will see the apparent heart size will be bigger. This is what happens in the heart. So you do not comment on the heart size, only sizes you comment only on a PA view. Okay? Understood, na? This projection was good. So this is a okay. This is a PA view. This is a AP view. So AP view, the characteristic you see, the scapula is within the lung fields. This is the end of the scapula. The clavicle is horizontal, and the quality of the X-ray always will be bad in an AP view. PA view, the clavicles are like this, and you will see the posterior ends of the ribs are better visualized. The anterior ends are not well visualized. Okay, and what was the other thing? The scapula. There is no scapula here in the lung fields. So this is a PA view. You will see these are the spinous processes. You can see 4. Beyond that, you can't see very well. Huh? So 4, 1, 2, 3, 4. Above the heart, 4 spinous processes. After that, you don't see. This is a well exposed fillet, and you see 1, 2, 3, 4, 5, 6. The 6th anterior part dissects the middle of the diaphragm. So this is the inspiratory phase, the normal inspiratory phase X-ray. This is a lateral view of the X-ray. It is very interesting. You see so many things. You see the humerus, the trachea, and the aortic arch. I will show you. There are beautiful X-rays. You can make out the heart. See the retrocardiac spaces now, so you can see it very well behind the heart. These are the 2 lung bases. No? So this will also, you can see the hyla end on. The hyla will be end on. So this is a lateral view X-ray. So you see the spines, the heart, the hyla. I will show you another X-ray of the lateral view. You can make out everything, the aortic arch and everything. Okay. So these are the left and right costophrenic angles. Okay. So this is a PA AP view, PA versus AP view, and this is a lateral view X-ray. So what are the lines? I like this because we were taught at one point of time. See, this is a relatively little overexposed film. Only then you can make out the lines very well. So you will see the aortopulmonary window. You see the aortic arch is like this. It's so nicely visible. This is the aortic line. This is the edge of the aorta, descending aorta. This is the paraspinal line. This is the paraspinal line. This part. This area is the paraspinal line. Not this area, mind it. It is the spine and the paraspinal region. If there is something here, you know there is on the lateral X-ray also you will be able to make out. So this is the paraspinal space. This is the azygos vein that goes up and drains somewhere here. So the esophagus, it will go by the side of the esophagus to be drained up. And this area can be visualized. It goes in and around the carina region. So if there is a carinal lesion, this line will be changed. The contour of the line will be changed. Then you can make out it is a subcarinal thing. Okay, and this is the paratracheal line that I was talking about. The trachea, the paratracheal line. This line is the paratracheal line. Okay, so we will see in other X-ray how the paratracheal line is widened in something there in the superior mediastinum. Okay, this. Let's see what we can make out in this. What is this? What is this structure? That is a prosthetic valve. Let us not comment what type of prosthetic valve it is. It is a prosthetic valve. Yeah? Can you make out a bulge here? That bulge is a bulge, the left atrial appendage. From top to bottom, it is the aortic knuckle, the aortopulmonary window. Here should be the pulmonary conus. This area should be the pulmonary conus. Here is the atrial appendage, left atrial appendage, and here is the left border of the heart. This is the left ventricular part. Can you see two lines here on the right side? This, interestingly, is the whole left atrium. There is a big left atrium at the back, and the right border of the heart is made by the right atrium. The whole of the right border of the heart is the right atrium. That is the left atrium only is found in the left atrial appendage part. Nowhere else you will find the left atrium. Here this is known as a double contour of the right border of the heart. So one border is for the left atrium, the other border is of the right atrium. Okay. Can you make out the lateral view X-ray? It is so nice. You can make out the heart. See, this is the aorta, this is the ascending aorta, the arch of the aorta and the descending aorta. You can make out everything in that X-ray. This bulge is the left atrium. So what constitutes the borders here? You see the aorta. The upper part is the left atrial part because the left atrium lies posteriorly. So in a lateral view, this is the left atrium. This part is the left ventricle, and here you see a structure. What goes into the right atrium? the inferior vena cava. This is the inferior vena cava. So you can almost make out the inferior vena cava. You see the left ventricle and the left atrium and the aortic arch. Beautiful, no? So this is a X-ray I liked. That is why I put it here. So you can also make out the sternal clips. So once a X-ray like this is given, you will give a description of the whole thing. So bones, you see the clips, the heart, you see the aortic arch nicely. You can see make out the left atrial bulge, and on this side you see double contour of the right border of the heart, and you can make out there is a dense structure which looks like a prosthetic valve. Okay, nice, good. So this is another X-ray I liked. This is how the heart, borders of the heart. See the left atria, that is the left atrial appendage, and on top of that you put the right atria. This is the right atria. So the right border of the heart is almost made up by the right atria. The upper part is made up by the superior vena cava. Just above the right atrium is the superior vena cava. Okay. The left atrium you see on the PA view, left atrium is obliterated. And then on top of that you put the left ventricle. The border of the left ventricle is seen on the left side. That is the, so here you see the left ventricular border. So this is why it is the atrial appendage and the left border of the heart, the left atrial border. The right border you can't see, it is below. For the whole thing is made by the, on the right side the whole thing is made up by the right atrium. Okay, and above this is the superior vena cava. Okay, and the right atrium is, the whole thing is behind, so you hardly see the right atrium. Okay, so this is how the heart, the shadow of the heart, you visualize it this way. Okay, so now comes the cardiothoracic ratio. This is something which we always talk about. So it should be assessed only on a PA view. So how do we assess it? So, but one thing is there, is that you take the widest part of the heart. You make a line in the mid-thoracic, that is a mid-thoracic line. That mid-thoracic line, on both sides you see the heart, the widest area you take. So it is A plus B is the cardiac size. You may not put a straight line through B might not be the widest area. So you take the widest area, the A plus B, and the thoracic ratio is at the level of the diaphragm. So it should be at the level of the diaphragm. So A plus B divided by C should be less than 0.5. So the cardiac size should be half the thoracic size. That's all. This is about the cardiothoracic ratio. Okay. So we were talking about the hyla. So this is how the hyla is made up of. The left atrium, these are the pulmonary arteries and the veins. The blue are the arteries actually. The red are the veins. So in a lateral view X-ray, this is how you see. This lower part you see the, so the pulmonary arteries are this, and these are the pulmonary veins. And on the projection on that side, the PA view, you can make out how the borders are made of. So that is the pulmonary conus. The main pulmonary is the pulmonary conus. This is the left atrial appendage. This is the left ventricular border. So this is the pulmonary conus, and this is the arch of the aorta. the arch of the aorta, the pulmonary conus, the left atrial appendage, and the left border of the heart, left ventricular border. And on this side, this is the whole thing is the right atrium, and here is the superior vena cava. So this is the anatomy of the heart superimposed on a PA view. Okay, if you can visualize this, you can make out what is what in a PA view. Okay, these are important. This thing that you asked me about the inferior pulmonary, somebody asked me about the inferior pulmonary arteries. So the inferior pulmonary, this area, these are the inferior pulmonary arteries. Okay, this you can see very well, actually, that is why the importance of it. So it will be the size of the little finger, the pinkies, like the pinkies, this way. No? So if see in on this X-ray, can you make out something on this X-ray? There the artery is there. Here there is no artery. The little pinky is not there. This is normal. This is not there here. So there is a thrombus in the inferior pulmonary artery, which has caused the medial part of the right lower lobe to collapse on the cardiac shadow. So that is why that slope is there. Now after the artery has been opened up, the opacity has gone. You can see the right border of the heart very nicely now. These are very subtle changes which you may be able to make out. Huh? Okay. This is how a pulmonary embolism was diagnosed at one point of time. So this is about the inferior pulmonary arteries. Okay. Can you make out? This should have been the paratracheal line, right paratracheal line. There is something here in the right paratracheal region. That is where the line has broadened. There is no line now. The whole thing has become a band. Okay. And there are few things here and here. So these are lymph nodes. That is a mediastinal lymph node. These are hilar nodes. So bilateral hilar node. Can anybody tell me about the differential diagnosis? Sarcoidosis. Tuberculosis also can be, but sarcoidosis is should be the number one in bilateral potato nodes, they say, na? So this is known as a 1, 2, and 3 sign in an X-ray of sarcoidosis. So in the examination, probably this will pass off as a normal X-ray, unless you try to individually see the components that you are to see in X-ray. Okay. So now comes the pleura. So pleural effusion is one thing we see there, very commonly seen. So around 200 to 300, that is how the obliteration of the CP angle, the CP angle should be. I have not gone into detail about the CP angle, cardiophrenic angle, those things you know. That is why I have not gone into those. Okay, detail. It will be boring. So the cardiophrenic angle, if it is just obliterated, the amount of fluid will be around 200 to 300 ml. If it is like this, you see a very beautiful meniscal sign. It will be around 2 liters or so. A whole hemithorax is obliterated, around 5 liters of fluid is there. A rough estimate. Now you can almost estimate by a ultrasound. So you see how a pleural effusion look like. A lateral view and a. So this is known as a meniscal sign. Why is it known as a meniscal sign? It looks like a semilunar type of thing. Why does it occur? Anybody know? That's an undergraduate question. Thickness of the fluid is more on the lateral part through which the X-ray has to traverse. That border, you can see it up to here. If you draw a straight line here, the fluid anterior part, this line should have been up there. But due to the capillary effect, there will be a thin film of fluid here through which the X-ray passes. But here, the film will be bigger. So you see the opacity here, you don't see the opacity here. Can you make out? So if I take a beam of light here, shine it, this part will be opaque, this part will be translucent. So there is some amount of fluid in this part also, but it is a thin film and it is only one film. So the X-ray passes through. Here it will be a wall of film, wall of fluid. So that is the reason why you feel up there also there is fluid. That is the reason why you get the meniscal sign. So once you get the meniscal sign, you are fairly certain this is fluid. Okay. So this is a pleural effusion. This is how you see it in a lateral view. So you can see the cardiophrenic angles here are obliterated, and not the cardiophrenic, sorry, the costophrenic angles on the lateral view are obliterated. So this is a pleural effusion, everybody knows. So can you tell me what is there in this heart? Is there a cardiomegaly? We will have to measure, but there seems to be a cardiomegaly. And you see there are the costophrenic angles, both are obliterated. You see, it should be acute angle. These are not acute angle. This has been obliterated. So there is bilateral pleural effusion with a cardiomegaly, and these vessels that you see, the radiating vessels from the hyla, you should be able to see these till around 2/3 of the lung. In the lateral 1/3, you should not be seeing blood vessels like white structures, you should not be seeing in the lateral 1/3. And the apical upper zones are less, more ventilated and less perfused. No? So the perfusion should be less. So there should not be blood vessels visible in the apical part. If the blood vessels are visible in the upper part of the lung, then you know there is congestion of the pulmonary vascular system. Okay. So there is congestion of the pulmonary vascular system, there is a cardiomegaly, and there is bilateral pleural effusion. This is a heart failure. No? So if you are given a X-ray like this, you will be describing everything about it. But you see there is a rotation of the film. There is a subtle rotation. The spines are not equidistant from the ends of the clavicle. If it is very less, you may still comment on the heart size. But if it is gross, you should not be commenting on the heart size. You can point that out to the examiner. Then it is a slightly rotated film. But these are the findings that I find. Okay. Agreed? So let us come to, we are talking about the pleura. So pleural effusion, and then comes the, everybody can say, there's a pneumothorax on the left side. No? So this is a characteristic finding. There is absent lung markings. There is the collapsed lung. You can see the edge of the lung there, and a shift of the mediastinum. So these are the cardinal features of a pneumothorax. Okay. There are various, a small pneumothorax is the easiest thing to miss in an X-ray. Okay. There are few signs in an X-ray which we will discuss at the very last, which will be our homework. where I will talk about just one of the sign which I find it very interesting. We will talk about pneumothorax in that sign. Okay, a subtle pneumothorax will produce some sign which if you see is very sure that there is pneumothorax. We will talk about it later on, but this is pneumothorax. This is pneumothorax. There is pneumo, no doubt. There is no vessels, but there is something more. In an X-ray, there should not be any straight horizontal line. If you see a straight horizontal line, this is abnormal. You see a straight horizontal line here. Is it hydropneumothorax? Everybody can diagnose. क्या दिक्कत है hydropneumothorax में? But this is 100% everybody is going to miss because there is a big pneumo and a very small hydro. So look for straight lines in an X-ray. If there is a straight line in an X-ray, that is abnormal. Okay, at the back of your mind. Interesting? Interesting. So we were talking about pleura. This is a pleural mass. This is how a pleural mass looks like. Now it is easy with a CT you can diagnose, but in an X-ray it will look like this. So we will not go into details. So now we come to the actual opacities in the lung. So it is a light shown through the body. What are the things that can cause a shadow to appear in a X-ray? So these are the things that can cause a shadow. If there is water, if there is infected pus or a pus-like thing, thick something there in the lung, if there is blood or if there are lot of cells packed together. So these are the things, these are the only 4 things which can cause a shadow in the lung, in the lung parenchyma itself. So water is heart failure, ARDS, fluid overload. Infected pus is pneumonia, pus-like material. Blood, it is trauma or pulmonary hemorrhagic syndromes. Cells, examples are non-infective infiltrates or bronchoalveolar carcinoma. Okay. These are the things, contents of an opacity in the lung. So what are the patterns? So we are concerned with the patterns that can occur in the lung. So these are the patterns. These are the few patterns. There are so many, but these are the most important ones. A diffuse opacity. If there is a diffuse opacity in the lung, we think of pulmonary edema, we think of hemorrhage, we think of infiltrates, infective or non-infective infiltrates. Infiltrate is actually a very vague term which is used loosely. Most of the terms in X-rays are very loose. So infiltrate are diffuse opacities are known as infiltrates. So if it is lobar, it can be a pneumonia or contusion or an infarct. If it is multiple ill-defined, so borders are not very well defined, it could be a pneumonia, it could be septic embolism, it could be Wegener's, it could be neoplastic. So edges are not well defined. So this is the reason why you get a speculated margin in a neoplastic lesion. Speculated is the regions are like spicules, the edges are like spicules going out from the edge. Okay. We see batwing patterns, we see reverse batwing patterns. Each of them I will show you in X-rays. Okay. Can you tell me what is there in this X-ray? So this is a diffuse infiltrate. Huh? So this is an example of a diffuse infiltrate where you will see the lobar, interlobar space, there is fluid collection. Okay, this is the transverse fissure. There are a few lines there which are perpendicular to the edge of the thoracic wall. These are the Carlisle B lines, beautifully shown here. If you see these here, you know these are Carlisle B lines. These Carlisle B lines are thickened interlobular spaces. So this causes the Carlisle B line. Okay. So there is cardiomegaly, there is fluid in the interlobar fissure, there are Carlisle B line. This is a heart failure. So this is pulmonary edema, a example of a diffuse infiltrates in the lung. Okay, and you see these vessels are going up to the top. So there is pulmonary congestion definitely. Can you make out what lobe it can be? Right? Middle lobe. Lower lobe? Middle lobe. Okay. The lower lobe, posteriorly, it is represented more posteriorly. So in that lateral view X-ray, this is the lower lobe part. This is the middle lobe, a triangular shaped structure. So this is a homogeneous triangular shaped consolidation area in the right side of the lung, probably a pneumonia. Okay. So this is the corresponding CT report looks like this. Okay. What should be there in a consolidation? How do you know it is consolidation or collapse? There should be an air bronchogram. You should be able to see airways within the opacity. This is more characteristic of a CT finding rather than a X-ray finding. But in X-rays also you tend to see. What are these? The edges you see are not very well defined. It's like absolutely out of focus thing. So these are multiple ill-defined lesions. No. Cannonballs are defined lesions. Okay, I'll show you what a cannonball looks like. These can be multiple ill-defined lesions, can be Wegener's or septic emboli. Okay, this is pulmonary edema. This is a batwing pattern. No? So pulmonary edema is also one diagnosis. A PCP pneumonia also will present like a batwing. So here you will see there are no evidence really of a cardiomegaly, or the upper part is fairly clear. You don't see infiltrates, you don't see blood vessels also there. So this probably is a case of PCP pneumonia. So if you see an X-ray like this with a normal heart and no blood vessels on the apices, then you will rather think of a infective cause than a pulmonary edema. Okay, this is a bat wing. It's like a bat swing. So next we will come to reverse bat wing. So what is reverse bat wing? Here you will see the lateral parts are clear, the upper and the lower parts are clear. The opacity is in the middle. Make it ulta, it will be reverse bat wing. So there will be opacities in the top and bottom, the middle part will be clear. This is a typical reverse bat wing pattern. Reverse bat wing pattern you get in pulmonary eosinophilia, pulmonary eosinophilic pneumonia. You get in bronchiolitis obliterans, organizing pneumonia, sort of organizing pneumonias. There, these are two examples. There are so many. You will read the examples. I also don't remember, tend to remember. It's there in the books. But this is the pattern of a The middle part is clear. All other areas are opaque, infiltrates in the lung. So this is a reverse bat wing pattern. Okay, this probably is a eosinophilic pneumonia. In BOOP, it is more patchy. Why is it a collapse, not a consolidation? So unless you comment on the trachea, you will always be wrong in this. So this is the reason why you are going to go step by step, step by step. Otherwise, you are going to tell this as a consolidation. This is a collapse of the upper lobe right side. Because the trachea is pulled towards it. You see, it is pulled. No? There is no rotation of the film. But still, the whole of the trachea is on the right side. So this is a collapse. Okay. So collapse and consolidations are difficult. You are going to see the deviation of the mediastinum. See, even if there is a opacity, you can still make out the paratracheal line. So there is nothing mediastinal in this, in spite of the opacity. In the other one, there was no line; it was a band. So that is why it was mediastinal. So nodular lesions. So diffuse, then comes nodular. What is a nodule, by the way? What is a nodule and a mass? So the size matters. Less than 3 centimeter, it is nodule. More than 3 centimeter, it is mass. There are two types of nodule. One is a micronodule, one is a macronodule. So less than 3 millimeter is a micronodule. Above 3 millimeter is a macronodule. Okay. So these are the few examples of micronodules. Miliary TB, silicosis, fungal, hemosiderosis. Hemosiderosis we tend to forget. So we get so many patients who are getting IV iron and things. Nah? So if you get a picture like this, it will be more likely to be a hemosiderosis than anything else. This is a X-ray of multiple small pinhead sized nodules. The size will be like a millet. So this is a miliary tuberculosis. Okay. There will be few very characteristic miliary tuberculosis X-rays which will not be given. An X-ray like this will be given. That is why I have given. So this is a miliary tuberculosis. So these are nodules which are more than 3 millimeter but less than 3 centimeter. So these are nodules that you find in nodules, this type of nodules, multiple nodules. So nodules can be solitary, can be multiple, can be micro, can be macro. So these are multiple nodules which are macronodules, bigger nodules, not the micronodules. So you will find in granuloma, lung CA metastasis. Okay. So this is a case of tuberculosis. A tuberculosis, a subtle tuberculosis like this. This is how a tuberculosis initially will look like. This is a very big chapter. Solitary pulmonary nodule is a very big chapter. So there are guidelines there in place of how you are going to follow up a case of solitary pulmonary nodule if you find one, and I think you should go through those guidelines. So you may get a question on solitary pulmonary nodule, evaluations, when to see, what are the differential diagnosis, which are the nodules which looks dangerous. So these are the causes of a solitary pulmonary nodule. It can be TB, fungal, malignant. You will find it in the book. So this is how a solitary pulmonary nodule looks like, and you will see that the pulmonary nodule is placed posteriorly on a lateral X-ray. Okay, you can make out the nodule, na? It's a small nodule there. Multiple well defined nodules can also be malignant, but a cannonball is a mass. Cannonball appearance, that cannonball is a big thing. It should be more than 3 centimeter. So, it is characterized as a mass, not as a nodule. But multiple nodule, well defined nodules can be malignant, can be metastatic. But if you say it is cannonball appearance, it should be a mass. So, these are cannonball appearances in the lung. Okay. So, there are many things, not only neoplastic, there are non-infective granulomas, TB, fungal, septic embolia, everything can be. A bigger thing is known as a cannonball, a multiple nodule like this. These are fairly well defined, you see. So, now let us go to cavity, lung cavity. So, what is a cavity? It is a gas filled space in an area of consolidation. Is a gas filled space inside a consolidation mass or a nodule. Okay. So, it can be thick walled, thin walled, it can be ragged border, smooth border, it can be single, it can be multiple. So, different diagnoses are there for different combinations of problems. So, what are the different causes of a lung cavity? It can be a lung abscess. Abscess is also a cavity. These are the differentials. Neoplastic, these are the differentials. In an infarct or a septic emboli, also you may get a breakdown in between and a cavity might occur. Inflammatory, rheumatoid and sarcoid, you get cavitary lung lesions. And in trauma, we should not be forgetting trauma as a cause of lung cavity. Okay. Any necrotizing pneumonia will also cause a cavity. So, that is why Staphylococcus and Klebsiella, these are the two, and aspiration, these are the 3 pneumonias in which you get cavities commonly. Fungal is another one where you get cavities. So, it is not all inclusive, just examples. This is a lung abscess. There should not be any straight line. There is a straight line. So, there is air fluid level inside an area of opacity. So, this is a thick wall cavitary lung lesion with air fluid level. This is lung abscess. Okay. These are easy. This is a cavity, but there is no straight line in there. So, it is just a cavity. This is not lung abscess. Okay. A cavitary lung lesion in the upper part of the lung. The first diagnosis should be tuberculosis in a place like ours. So, this is a ragged border area where the lung cavity is, the area around it differs. It is not a very well defined area. An infective lesion will have areas of consolidation outside the cavitary area. So, a tuberculosis, a staphylococcal pneumonia, there is a breakdown of that area actually, that is caused the cavity. So, there is necrosis in that area which has caused the cavity. So, in a infective cause, the area around it will be infected, might not, the whole thing might not cavitate. So, there will be areas of opacities around it which are not very well defined. So, ill defined ragged border cavitary lung lesion. So, there are multiple cavities. So, a multiple cavity, one of the diagnoses is vaginous. Huh? And these are not infective minded. That is why you don't see much areas of consolidation around it. These are cavitary lesions because of vasculitis. So, it is clean. The areas around the cavity are quite clean. See. So, this differs from an infective multiple cavity lesion. Okay. Interesting, no? This is a vaginous X-ray. Now, we come to interstitial. What is the interstitium in a lung? The space in between the alveoli. Okay. So, interstitial shadows can also be seen. So what are the different types of interstitial shadows? It can be the pattern can be, we are concerned with pattern always, okay. So interstitial shadows pattern can be reticular, can be reticulonodular, can be honeycombing, and can be ground glassing, okay. We have examples for that, and these are the causes of a interstitial shadow. I will not go into detail about interstitial lung disease and other things, because we are discussing about X-rays, not about the disease itself. So there are so many things that can cause interstitial shadows. Pulmonary edema is also one, okay. So pulmonary edema initially will come with only interstitial edema. So there also you will find reticular, fine reticular shadowing, okay. So that is why example of pulmonary edema is there. COVID is another example. Alveolitis and hemorrhage inside the alveoli. So these can cause interstitial shadows. What is a reticular shadow? What is a reticulonodular shadow? This is a typical reticular shadow, and that is a reticulonodular shadow. So there are small nodules, if you can make out, and there are lines, and here there are only lines, there are no nodules as such. So this is a typical reticular shadow, that is a typical reticulonodular shadow. If you may, I may agree that there is some ground glassing as well on that X-ray. There might be, okay. If you say, I will agree, but it is basically a reticular nodular example of a reticular nodular shadowing. That is a reticular shadowing. Reticular you can make out, na? So that is why I put this here. So these are line intersecting lines. These are the interlobular fissures that are thickened, okay. So what is a ground glass? A frosted glass is also a ground glass. So this is an example of a glass which is grounded, a ground glass. A opacity like that in an X-ray is a ground glass opacity. You can make it out very well in a CT scan more nicely rather than a X-ray, but this is an example of a COVID patient who has a ground glass opacity in the, predominantly a ground glass opacity on the lung fields. So this is a alveolar, these are actually opacities because of something there in the alveolus which is caused. What are the things that can cause opacities? It is there in the causes, no? Fluid, blood, those things. So it can be blood, it can be some fluid, but if it is in the alveoli, it will not be as big as nodules. No? Alveolar hemorrhage, a flare of an ILD, anything inside the confines of the alveoli will be alveolar opacity like a ground glassing, okay. See up to which part is the diaphragm pushed down in this? It is numbered 1, 2, 3, 4, 5, 6, 7, 8. The 8th rib is dissecting the middle of the right side of the diaphragm. So this is a overinflated lung. This is a case of emphysema. Let us go to this X-ray. So emphysema everybody has seen. These are rounded opacities as if there is a cavity here. It is in the alignment of the bronchus. Here you will see a tubular structure there, no? So this is a case of bronchiectasis, subtle. If there is a big bronchiectasis, it is very easy to see, but these are subtle bronchiectatic changes. What is that sign known as? No, this is tram track sign. That is a tram track. It is like a railway track that you see. So you can see this tram track here also. So if you see a tram track like opacity, this is bronchiectasis. So this is a case of bronchiectasis. There are so many bronchiectatic X-rays, which are very visibly you can say, but this is something which you might miss. Let us go to the lateral views a little bit. Okay, so the mediastinum can be a superior mediastinum, anterior, middle, and posterior mediastinum. Okay, so we will not go into the anatomical definitions of anterior superior. Everybody will know, but you see in this there are hilar shadows in this PA view X-ray. There are shadows on the right side is the lateral view, and this is the hilar area where there are roundish shadows. These are nodes in the hilar region, hilar lymph nodes. Okay, in the hilum. On that side is, see, you will tend to miss because it is behind the cardiac shadow, that PA view. There is a opacity there, which you can very well make out on a lateral view. So that is a posterior mediastinal mass. Okay. So in a PA view, you will miss it out, almost miss it out. In a lateral view, it is absolutely evident. So that is the importance of a lateral view. CT is something else, but lateral view also you can make out. It's a posterior mediastinal mass. Your differential diagnosis will completely narrow down to few. Okay. Here it looks like a lung mass. Here it looks like a anterior mediastinal mass. In a lateral view, this is the anterior. This is the anterior mediastinal mass. How you see in a X-ray, a PA view and a lateral view. Okay. So in the thoracic wall, this is how a surgical emphysema looks like in an X-ray. Everywhere there is air. In the thoracic wall there is air. So this is a surgical emphysema. So we have come up to the thoracic wall. Now let us go to the bone. There are many things that you see in the bone. Fracture is one which you see. Mind it, if you don't look for fractures in a CT, it is really difficult to make out fractures in a CT. Fracture of the ribs. It is very easy to make out fractures of ribs in an X-ray. If you have to tell the radiologist that I am looking for a fracture in the rib, he will be able to find it out by making different projections of the CT. But just by looking, if you just say look at the CT, he will tend to miss on the fractures in a CT. You will almost always make out fractures in a X-ray because there is discontinuity in the line of the bone. So this is a subtle fracture of the rib there. This is an example of a fracture in the rib. Okay, so when you have a pneumothorax, always tend to see the bones because one of the cause of pneumothorax is a trauma where you may get a fracture in the rib as well. So once you get a pneumothorax, you always see the bones nicely, so that because on the X-ray itself you can say this patient had a trauma. That is why he had a fracture in the ribs, and that is why he had a pneumothorax. So almost everything you can say just by looking at the X-ray. We are coming towards the end. Was it interesting? Yes. So this is for you to read. There are so many signs. There are so many signs. Silhouette signs, cervicothoracic. There's so many. I hardly know few of them. Hampton's hump. You must have got it in. You must have got it in MCQs. Nah? I am very interested in that continuous diaphragmatic sign. You see this one. What happens is that the heart actually sits on the diaphragm, so you cannot make out the middle part of the diaphragm. If you can make out the middle part of the diaphragm as well, that is a pneumothorax. Pneumomediastinum, pneumothorax, whatever it is, there is air in between the heart and the diaphragm. I am interested in that continuous diaphragmatic sign. If you see it, you know this is pneumothorax. Otherwise, you do a CT only, then you can find out. With an X-ray, a continuous diaphragmatic sign is a pneumothorax. Interesting, no? So, these are the different signs. I don't know. Few I don't know, few I know. But it will be beyond the capacity, my capacity to carry on with these signs. You will do as a homework. Thank you very much. Thank you. Thank you.